Looking good. Thank you very much. So first of all, these are my disclosures. And I will start off for you with the history of this disease. And it all started with Alfred Wiskott, who, as Fabio just mentioned, at the time was the director of the Dr. von Hauner University Children's Hospital in Munich. And he was a pediatrician, and he saw a family with 3 affected boys who also had 4 healthy sisters, and they were all suffering from very early onset bloody diarrhea, draining ears, and eczema, and they all died at 4, 8, and 18 months respectively in the absence of any curative therapy at that time. This is an original chart that he did for his publication with all the 3 children, and this is eczema occurring from month 12, edema, then this child had colitis, and sometimes diarrhea, and then finally died. And these black areas are bleeding episodes, and child B and child 3, and so they all died in the late 20s and early 30s of last century. And this was the original publication that he created from this, and he called it familiäre angeborene Morbus Verloffi, which means familial congenital ITP, or immune thrombocytopenia as we know it today, because he clearly realized that the thrombocytopenia was a hallmark of this disease, and this is in some original drawing where he pointed out where the eczema was and the petechial bleeding on the back and the front of the child was. And in 1964, actually after Aldrich had described the family as the disease as well, Wiskott was asked to give a talk at the German pediatric meeting, and he, trouble reading it down here, whoops. He reported that he had never seen any other family with the same disease, but there had been patients reported from the US, from Switzerland, Italy, England, Denmark, Greece, Netherlands, Sweden, and Spain. So it became clear that this was not just it was a rare disease, but it was a disease that appeared in all countries, all races, and that's still true for today. And he also mentioned that one of the healthy sisters of the brothers had a male offspring, and then we later found actually a great nephew of these sisters, and he was diagnosed with Wiskott as well. By that way we could prove that these 3 children that were already described by Wiskott actually had a mutation in the Wiskott-Aldrich syndrome gene. Unfortunately, Wiskott practiced during very dark times in Germany, as you all know, and he could not have been not affected by this. And between 1940 and 1945, the Nazis unfortunately operated so-called Kinderfachabteilung, which means special children units or wards, where they chose to murder helpless children who were sick or had other disabilities. And sometimes they were brought in by the families even, or they were taken from the families and relatively quickly murdered there. And over 300 children died at this institution close to Munich, which was in Haar. And since Wiskott was the head of the main children's hospital in Munich, he clearly knew about this institution, and that has also been historically documented. And so far, we could not document that he was directly involved in referring children there or sending children there or educating doctors who were there. But actually the research is still ongoing, and the dean of our faculty has engaged in a research activity and going into the archives and trying to find out, because we think that is also important to know. Robert Anderson Aldrich, he was also a pediatrician who practiced at the Mayo Clinic, and he, not knowing about Wiskott's publication, which was in an obscure German pediatric journal, which of course he had no access to in the absence of the internet. So he described an unrelated Dutch-American family with 16 affected boys from sixth generation and very clearly described the sex-linked nature of the disease. And I really like the image of the pedigree that he originally described, because it's so not only beautifully drawn, but it also very clearly demonstrates that this only affects boys, and they inherit the disease via the X chromosomes from their respective mothers. And he nicely in his manuscript described the situation when he was taking the history of these families, and it was going nowhere. And then finally the grandmother, when she was questioned, gave the important lead when she just said that it's just like all the rest of them, so indicating that they had all the same symptoms, presumably ear infections, bloody diarrhea, bleeding episodes, and eczema. So I will actually stop with the ancient history of the disease here, because I think today we're more here to discuss more up-to-date issues, but I will come back and refer to some milestones that have led to the situation where we are today. And please excuse me, Fabio, I will do a very short excursus into the clinical manifestations of this disease, which you will come back to in much more detail, I am sure. But we all know within this room that WAS is characterized by mainly 5 different symptoms, one of them being typical eczema, one of them being thrombocytopenia or low platelets, one of them being an immunodeficiency, which can be very variable. Autoimmunity plays a huge role and can have very different manifestations, and I'm sure we will hear much more detail about that. And also malignancy. So patients with WAS have a relatively high risk to develop malignant diseases, especially lymphoma and leukemia. It's of course X-linked and caused by mutations in the Wiskott gene, and I will not go into this detail, and I'm not sure Adrian will do it. I think he sketched it. But it just goes to show that the cellular consequences of mutations in the WAS gene cause very, very diverse pathology within the bodies of the patients, explaining why there's so diverse manifestations, but also a high diversity in patients experiencing pathology, meaning that patients can have very different manifestations of the disease. These are some original drawings by Wiskott on this side, and a patient of ours on this side, clearly showing what in classical WAS the eczema looks like in infancy. And you can see this patient already has a central line, so he's being prepared for stem cell transplantation. And this nice little boy, who's not in the room, but his mother is, shows the typical sign of petechia on his face, and here he has a hematoma after some bump. I don't know what happened exactly, and you can see the bleeding eczema on his lip. And this is a blood film, I don't know if his or any other patient, but it shows you, so these grayish things are red blood cells, this is a white blood cells, probably a lymphocyte, and these little dots are the platelets, and they are very small. You just have to believe me because you don't see the normal platelets next to them, but they should at least be twice the size of these little dots. And what is very important to stress, and I think many of you know, especially if you have affected families members, that Wiskott WAS has a very strong disease severity continuum, and it can vary from very mild disease to very severe early onset disease, and all the 5 hallmarks of the disease can pretty much occur in any patient relatively independent of each other. And there have been multiple attempts to classify the severity of the disease either, and I'm sure we will come back to these classifications during the course of this conference, as classic was, mild was, XLT, which stands for X-linked thrombocytopenia, intermittent XLT, which means patients only have intermittent thrombocytopenia, but not all the time. And there's a quite separate version of the disease, which is called X-linked neutropenia, affecting patients who also have mutations in the WAS genes, but these are activating mutations, and that causes neutropenia. These are very rare patients, and I don't think we will talk much about them during the course of this conference. I just wanted to note that that's also possible. Hans Ochs, who should have been standing here right now, designed a clinical score, which was by the time very helpful, so we could categorize the disease severity, and it's still being used today, but although some of you may know that my opinion is we should not use the score very extensively, because it can only be retrospectively applied to a child, and it's not helpful before the age of 2 years, because the disease itself may still develop in its severity. But the diagnosis of WAS is very often established before the age of 2, and that's when we need to make decisions. And a progression from one of the lower scores to any of the higher scores during life is not uncommon. On the contrary, it happens quite frequently that patients with, for example, XLT or a score of 1 develop autoimmunity and then automatically are categorized as a score of 5. So it's really not that helpful to make a decision that is a treatment decision that should be looking into the future. I will briefly also touch on the treatment options, which we will discuss in further detail during the conference, just to give you a first impression. Of course, there's conservative therapy, by which we mean antibiotic prophylaxis in some patients, immunoglobulin substitution, trauma protection to protect the children from bleeding, which works very well in very mild or mild patients, but it clearly does not reduce the risk for autoimmunity or cancer. Then there's splenectomy, which I'm sure we will hear more about, which can be very helpful to increase the platelet counts and thus reduce the risk for bleeding, but it also increases the risk for sometimes fatal infection, and also presumably does not affect the risk for autoimmunity or cancer. Then, of course, there's stem cell transplantations, which we will talk a lot about, I think, because this has long-standing been a therapeutic option that can cure the disease if successful, but it has its issues, obviously, being acute and long-term toxicity from chemotherapy, and also an inherent risk for what we call graft versus host disease, or GVHD. This is an unwanted immune reaction of the donor against the recipient body, and I will refer further to that during my talk on transplant. And then there's a new kid on the block as gene therapy. Actually, it has been on the block for over 10 years now. We know that it improves the disease, maybe cures it for some patients. There definitely is no risk for alloimmunity, because you don't use a different person as a donor for the cells, and you still need chemotherapy, although it's significantly less, and I'm sure we will have many more details from Alessandro Aiuti about this. I will quickly touch on the historic milestones, because that's what this talk is also about. So I mentioned that in 1937 the disease was first described, and then for a second time described in 1954, which consequently led to the designation as Wiskott-Aldrich syndrome. In 1964, X-linked thrombocytopenia was already suspected to be a variant of WAS. And then in 1968, the first successful allogeneic stem cell transplantation, so more than 50 years ago, was reported and was successful. In 1994, the gene for WOS was discovered, which really made diagnosis much easier and also sped a lot of knowledge, or sparked a lot of new research, and increased our knowledge about the disease. In 2001, X-linked neutropenia was first described as also associated with mutations in WOS, which was surprising. And then in 2010, the first successful autologous stem cell gene therapy was reported. It is very important that we have a look at natural outcome of the disease, especially because the variability of severity is so diverse. And I don't know if all of you are familiar with these Kaplan-Meier survival curves, but since we will see them a lot during this meeting, I will shortly explain what they mean. So down here you have a time scale, which could be in months, or in this case it's in years, and counting from birth. And on this axis you have the probability for survival. And so a patient would move along the time scale, and if he is alive, of course has a probability of survival of 1 or 100%. And if you have a group of patients, if there is a so-called event or a death in this case, the curve would go lower because the probability for the entire population would be lower. So for example, this curve would tell us that at age 20, in this cohort of patients, the probability to be alive was about 50%, while at age 5 it was still something like 80%. So these were the first larger cohorts of Wiskott patients who were described, and you can see that the prognosis at this time was very bad. This is 15 years, 20 years, so most of the patients had died at age 20, and actually the majority of the patients would die within the first 5 years of life. This was a somewhat later publication, but still not including transplanted patients, and this is taken from a study from Seattle, where also the outcome was still relatively bad. A few years back, we studied a cohort of patients with the by then called XLT phenotype, or the very mild patients, and we could show that if we only look at these very mild patients as a group, those were 173 patients, we could demonstrate that their survival was actually very good and quite comparable to the normal male population, but that these patients still had very high frequency of severe disease-related events, meaning that while these patients, if they had a mild disease, could survive well into adulthood and even further, they would still have events which could be life-threatening and could also impact their quality of life significantly. In the 2000s, there was a study, or were actually a couple of studies published, who looked at the expression of WOS protein, because with Wiskott, some patients have mutations that allow for a little bit of WOS protein to be expressed, or even almost normal amounts of protein to be expressed. And it's usually the case that these patients have a somewhat milder disease. And in this study, they could nicely show that actually the patients who were positive for protein had a much better survival than those who were negative for the protein. However, if you looked at the survival without intracranial hemorrhage or brain bleeding, there was actually not that much of a difference, especially for the first 15 years of life, even though later on the curves separated. So it's not a perfect predictor for disease severity. And the other problem we have with this is that there is no defined laboratory assay to test for protein expression. There's at least 2 different methods, flow cytometry or Western blot, to do that, and they cannot be compared side by side. And it's also not defined in which cells one would look for the protein. It could also be, the test could also be skewed by so-called somatic reversions, which means that in some cells of the body, the Wiskott mutations has been corrected just by pure chance of biology, and then in these cells or cell lines, the protein expression could be normal, and this could skew the total test result, even though for the patient himself it doesn't make such a big difference. So this is a problematic test which I don't think should be used actively to do treatment decisions on. So the problem that we will be discussing throughout this day and tomorrow is that there is more than one therapeutic option for Wiskott patients, being transplants, splenectomy, gene therapy, or conservative therapy, but that the disease severity at diagnosis is sometimes very hard to predict unless you have a patient who presents in infancy with all the classic symptoms. Then you know that this is a severely affected child, but that's not always the case. In such a rare disease, it is not feasible to do the optimal scientific standard of a clinical study, which would be a randomized trial. It's just not possible and also not financeable. And this makes consulting families with this disease very tricky, and it's one of the reasons why we're here today to discuss many of these questions. In 2016, we looked at a cohort, which unfortunately we have not published yet, but will, of more than 500 WAS patients, and just complete picture of WAS patients around the world. And this was the frequency of the therapy these patients had received. So you can see that many patients had had a transplant, but there were also very many patients who did not have any curative treatment. And what we could show is that the overall survival, which you're now familiar with this curve, and the light blue is the so-called confidence interval, accounting for the possible that this is a statistic. So this curve could also be up here, statistically speaking. And this, as many patients had received a transplant, and they usually receive that transplant at an early age, down here around 5 years or earlier, this curve is censored for this patient. So for the severe Wiskott patients, this is an overestimate of their survival, and for the mild Wiskott patients, it's probably an underestimate. But it kind of approximates the disease picture as we're looking at in 2016, or were looking at in 2016. But what it did allow us to look at was the incidence of those severe disease manifestations, especially bleeding, infection, autoimmunity, and malignancy. And we defined severe as leading to transfusion for bleeding or being life-threatening or being a brain bleed. Infection as an infection leading to hospitalization with respiratory support, any type of respiratory support, or infections such as meningitis or encephalitis, who are by definition life-threatening. And then autoimmunity and malignancy. And you can see that the incidence, cumulative incidence, so this is actually the other way around of the survival curve. So here you have a starting point with a probability of 0, and then the probability to develop any of these complications goes up with age. And I don't know if you can read the scale. This is about 30 years. This is 15 years. And you can also see that beyond 30 years, the patient numbers become very low, so the possible statistical error becomes very large. We therefore decided to do something else with these data, and this is a picture of the Wiskott gene, and I'm already running late, is that correct? A little bit. Yeah. I'll speed up from now. Sorry. This is the Wiskott gene, and these are all the different mutations that had been found in a large cohort of patients. And this is the same cartoon, only for the patients with a very mild phenotype. And you could see that there's a certain type of mutation that clusters within exons 1 and 2 of the disease, so-called missense mutations. And there is another hotspot here in intron 6 for these very mild patients. So what we did is we grouped all these patients with these mutations, so missense mutations, exons 1 and 2, or this intronic hotspot, together as so-called mild mutations, and compared the outcome to patients with any other mutation. And not surprisingly, we could find a very significant difference in overall survival between these two groups. But we could also show that the incidence of severe events is significantly different, at least for infection and autoimmunity, and it looks also different for bleeding, but not for malignancy. But if you look at the probability, and the black curve is the mild mutations, and the red curve is all other mutations, but it shows that the events usually just occur much earlier in patients with all the other mutations, while in the patients with missense mutations, they also happen, but the probability is lower, so it takes a longer time for it to reach the same cumulative incidence, especially for infection and autoimmunity. So the outcome is still poor for patients with classic WAS phenotype without a definitive treatment, which should be stem cell transplant or gene therapy. And the survival for patients with mild mutations is good, but frequent severe events still happen, which may impact quality of life. This is, in short, the summary, but it doesn't answer really all of your questions, because I think we have a very large number of open questions still in 2019, and I almost copied this slide from 2017, because unfortunately, even though we have more data, we will still not be able to answer all these questions to the best appropriate level. And we will address many of these questions during the conference, and I'm not going through any one of them, all of them right now, because just for time's sake, but we will address all these, unfortunately, without the WAS carriers, which unfortunately I think is one of the talks that had to be canceled, which I regret. So with this, I would like to finish, and thank you for listening. And I'm not sure how we will arrange the questions. I think we'll probably do that in a panel style. Is that correct? At the end of the talks?
But I mean, further questions right now. Michael.
Can I ask a question?
Sure.
These probably, you probably can't answer this, but because a lot of these test results are for little kids, probably, right? Because in all of my kids that have Wiskott, puberty was really difficult for them. And then went through lots of autoimmune and lots of other issues. So have you seen that or no?
Yes, and that's actually not atypical. So if you or let's look at this curve for this. If you look at the incidence of autoimmunity, and it's very hard to read the scale, but the first tick here is 15 years already. So the probability to have an autoimmune complication increases during childhood, and at 15 years reaches about 25%. So it's not uncommon that patients would develop their autoimmunity even after the age of 15, so because the curve still goes up until the age of 30. So it's actually more the rule than the exception that any of these complications would occur later in life. Not saying that it cannot happen during the first 3 months. It's also possible.
That was our experience when they all hit puberty. That's when they kicked into that. And my oldest is 37, and I can say as well that he's been really doing really good for a while now. So.
Yeah.
It is possible that autoimmune that develops during the period of puberty and to the age of 15. Can it be possible that the autoimmune can be that.
Mm-hmm.
The graph doesn't say it's only increasing. It's not getting down.
Yes.
26 and quite good.
That's actually an excellent question, and thank you for bringing this up because I probably didn't explain it correctly. So what this is only this graph is a scientific graph, and it only records the first diagnosis of autoimmunity. But what it does not say is that in any individual patient, the autoimmunity could occur at some time, say 10 years of age, then go on for 2 to 3 years, and then slowly disappear. That is known to have happened, and it is actually quite common for some autoimmunities, like, for example, autoimmune cytopenias, which tend to occur in episodes and are not ongoing, chronically ongoing, while on the other hand, other things like vasculitis or colitis are more of the chronically ongoing type, but they can also come and go as well. Thanks.
My son received 2 kinds of cancer. The first one was leukemia, it was a drop. The same year, quite recently, here he received a bone marrow transplant. Now Alejandro is 4 years old, and he has bronchiolitis obliterans, and he has autoimmunity in his brain and his spinal cord.
Mm.
So in September last year, doctors found myelitis obliterans, and last week he discovered an inflammation in his brain.
Mm-hmm.
So have you seen another case like him? In Colombia, Alejandro was the first case that he didn't present symptoms of Wiskott-Aldrich.
The short answer is no, but it only illustrates that these patients can be very, very different in their presentations and also the timing of their presentation and their complete individual disease manifestation. That's what I was trying to allude with one of my first slides too. Right.